Hello, I'm Dr. Stephen Reidbord, and this is More Than Meds, where I talk about psychotherapy and psychologically informed psychiatry. Psychiatrists are trained to do it all, but most don't. So in this video, I'd like to talk about what it means to be a psychiatric generalist. Most office-based psychiatrists in the United States mostly do medication management. Many see some patients for longer appointments, and sometimes they call that psychotherapy and bill for it that way, but that all depends. It all depends on whether they're really pursuing a psychotherapeutic treatment. Psychotherapy, just to remind you, is a treatment intended to help a person change. Or if it's just being friendly and chatting and talking about your pets or the sports teams or what the weather is doing outside, even if it's billed as psychotherapy, it's not psychotherapy. In fact, that could even be called insurance fraud, potentially. So the first thing to do is to distinguish friendly, chatty medication management and psychotherapy. And you can't always tell that by how long you're in the office. In contrast, a small number of psychiatrists practice psychotherapy exclusively. They don't do any medication management. Many of those psychiatrists are trained as psychoanalysts, which is a specialized training that takes additional years after finishing a specialty training in psychiatry. There's then a psychoanalytic training, which also includes one's own psychoanalysis. And then after all that training, many such psychiatrists only do psychoanalysis or psychoanalytic therapy and don't do medication management. And then there are psychiatric generalists like me. My practice is primarily psychodynamic psychotherapy. I'm not trained as a psychoanalyst specifically, but I also do medication management. There's a saying that if all you have is a hammer, everything looks like a nail. That's the problem with being a specialist. We need specialists, but a specialist in medication management will be looking for medication solutions to the problem. A specialist in psychotherapy will be looking for psychotherapy solutions to a problem. In contrast, it's good to have a variety of tools in your toolbox, not just a hammer. If I'm meeting with you for psychotherapy, I'm still a doctor, a physician. I might notice a medical issue or something you mention could tell me that there's a possibility of a medical issue that might be affecting how you are thinking and feeling. There are a number of such medical issues that can affect your mood, your anxiety level, your sleep, and so forth. Or maybe it's unrelated to what we're talking about in psychotherapy, but it's a good thing for me to notice anyway. Conversely, if I'm seeing someone just for medication management and there are difficulties with the way we're relating to each other, or if the patient keeps forgetting to take their medication or is resistant to doing so, I can put my psychotherapy hat on and bring additional thinking to bear on what that problem is, because I will naturally think of it as a psychotherapist. In fact, we could convert the medication visits to psychotherapy visits if that's called for. Now, it's important to note that this isn't being a dilettante. It's not dabbling in this and that, trying a little of this, trying a little of that. It's important to choose one's tools out of the toolbox. It doesn't have to be one. I could do medication management and psychotherapy with the same person. But I'm not trying a little of this and a little of that. It's also important to pay attention to the effect on the patient, depending on what tools I'm choosing. For example, it wouldn't work very well if you were having a chatty, friendly kind of relationship with your medication-providing psychiatrist, who then one day you come in and they're all stone-faced and different because they decided to try some psychotherapy on you. That doesn't make any sense. I've also heard of psychotherapists who decided to throw a little CBT, a little cognitive behavioral therapy, into their dynamic psychotherapy to see how it would work. You can't switch gears like that. It's confusing for patients. You can try different things. You can introduce new ideas, certainly, in a psychotherapy, but this isn't like, oh, I think I'll try this week and I'll try that the next week. Many years ago, an online critic I was dialoguing with criticized the idea of being a psychiatric generalist. He said it was like being a spork. That's a combination of a spoon and fork that doesn't really do either job very well. I would say a better model, though, is a Swiss Army knife. We're not talking about one tool that does several things badly. We're talking about choosing tools that do work and that are sharpened or honed for their specific uses, and then not using other ones. Also, it's really important that mental health professionals don't denigrate our colleagues. None of us has a toolbox big enough to hold all the useful tools. It's important to know and respect what other mental health professionals can provide. Refer to a couples therapist if couples therapy is indicated and you don't do that yourself. I do a little couples therapy, but I still will refer out sometimes. I definitely refer patients out if they need a medical kind of treatment that I don't provide. For example, if they need ketamine for depression, or TMS, transcranial magnetic stimulation, for depression. I don't do that in my office, and so it's important for me to know and respect that other people do. When I was in medical school, which was when dinosaurs roamed the earth, I was taught that about 85% of all the problems patients brought to a general practitioner or a family doctor could be handled by that doctor, that they didn't need a specialist. Now, things have changed over those many decades, and specialists are resorted to more often nowadays. But it's good to keep in mind, there's value in working with somebody who sees wide and not just deep, who considers the physical and the mental, your social life, your social environment, and your inner life. There are no perfect psychiatrists or perfect anybody else either. But I believe being a psychiatric generalist is the closest we can come in my field. And that's why I'm proud that I am one. That's it for this time. If you have any questions or comments, please put them in the space below. Please refer to this wonderful video, which will talk more about the use of psychological principles during medication management. And I'll see you next time. Bye.